Okay, let's talk about a really tough diagnostic challenge. Imagine this, a sudden, absolutely excruciating pain in your face. It's debilitating. Now, what if I told you there are two different conditions that can cause this, and they look almost identical at first glance? Well, today, we're going to untangle that exact confusion. We're diving deep into the key differences between something called SUNCT syndrome and trigeminal neuralgia. And I promise, by the end of this, you'll see exactly how to tell them apart.
So let's frame this as a tale of two pains. Think of it like a medical mystery. You have this one single symptom, this awful facial pain, but two completely different culprits. And here's why it matters so much. Getting the diagnosis right is absolutely critical, because the path to relief, the treatment, is totally different for each one. This isn't just an academic puzzle. It has real-world consequences.
So that brings us to the big question, right? When someone is describing this agony, what are the specific telltale signs you need to look for? What are the little clues that point you down one path instead of the other? Let's break it down and find those clues.
All right, before we can solve this puzzle, we got to meet the suspects. We need to get properly acquainted with each of these conditions on their own terms. You know, what makes them tick? Once we understand them individually, comparing them side by side will make a whole lot more sense.
First up, we have SUNCT syndrome. Now, the name itself is actually a fantastic clue, because it's an acronym. It stands for Short-Lasting Unilateral Neuralgiform Headache Attacks with Conjunctival Injection and Tearing. Ooh, that's a mouthful. But basically, the definition is baked right into the name. We're talking about very brief, stabbing pains, usually around one eye. And here's the absolute key: they always come with physical signs, like a red, bloodshot eye and tearing. That part is non-negotiable for SUNCT.
And our second condition? That's trigeminal neuralgia, which you might also hear called Tic Douleraux. This is a whole different beast. It's a disorder of the trigeminal nerve itself. The classic description everyone uses because it's so accurate is an electric shock. It's this sudden, sharp, shooting pain. And what's really fascinating here is that it's almost always set off by specific triggers. I mean, something as simple as chewing, talking, or even a light breeze hitting your face can set it off.
Okay, so now we know the players. It is time for the main event, the clinical showdown. We're going to put these two conditions head to head and really dig into the features that set them apart. This is where the diagnosis happens.
Now this table really lays it all out. Let's walk through it. Look at pain duration. See how SUNCT is seconds to minutes, while trigeminal neuralgia is even shorter, like lightning bolts. But here's a huge one: autonomic features. For SUNCT, those features, the red, tearing eye, are mandatory. You have to have them. In trigeminal neuralgia, they're pretty much always absent. That's a massive clue. Now, let's talk triggers. Trigeminal neuralgia is famous for being set off by touch or activity. SUNCT attacks, they're often totally spontaneous, coming out of nowhere. And check this out: refractory period. After a trigeminal neuralgia attack, there's a period where you can't trigger another one. SUNCT doesn't have that. Then there's distribution. SUNCT loves the area around the eye, the V1 distribution. Trigeminal neuralgia, more commonly V2 and V3, the mid and lower face.
But you know what might be the single most powerful clue of all? It's how each one responds to a specific medication. See, with trigeminal neuralgia, a drug called carbamazepine often works like a magic bullet. The response can be so dramatic, so excellent, that it's practically considered diagnostic. If the pain vanishes with carbamazepine, you're almost certainly looking at trigeminal neuralgia. But for a SUNCT patient, that same drug does next to nothing. This difference is a huge, flashing signpost on the diagnostic road.
So why are we going through all this trouble? Why does this level of detail matter so much? Well, because it leads us directly to the treatment divide. Getting the diagnosis right isn't just about being clever or acing a test. It is the only way to get the person suffering on the right medication and on the path to feeling better. These treatment plans are not, and I mean not, interchangeable.
Let's look at the playbook for trigeminal neuralgia. The path here is pretty well established. As we just talked about, you start with first-line meds like carbamazepine or oxcarbazepine, and they tend to be super effective. If for some reason those don't work, or maybe the person becomes resistant over time, you can move on to other options. And for the really severe, tough-to-treat cases, there are even surgical procedures that can bring relief.
Now, let's flip the coin and look at the treatment for SUNCT. It's a totally different world. That wonder drug for trigeminal neuralgia, carbamazepine? Yeah, it's not the go-to here at all. The first-line medication is actually lamotrigine. Other options might include drugs like topiramate or gabapentin.
And to stop a really severe bout of attacks right in its tracks, IV lidocaine can be used. See? It's a completely different playbook, and it all hinges on getting that initial diagnosis spot on.
Okay, we've gone through a lot. The definitions, the head-to-head clinical features, the completely different treatments. So let's boil it all down to the most important takeaway. If you only remember one thing from all of this, please make it this next part.
Here it is, the absolute core of it. When you think SUNCT, think short stabs of pain with tears and redness. The physical signs are the big giveaway. When you think trigeminal neuralgia, think triggered electric shocks that get better with carbamazepine. The trigger and the response to that specific medication, those are your guides. If you can nail these two profiles, you've solved the puzzle.
And that really leaves us with a final thought, doesn't it? Pain. It's the body's way of sending a message. It's an alarm bell. But when two totally different problems ring such similar sounding alarms, it just highlights how vital it is to be a precise translator of that pain. It's all about listening for those subtle, tiny differences, because those differences change everything.